Good afternoon. This hearing will come to order. I want to welcome everybody to today's hearing titled Persian Gulf War, an assessment of health outcomes on the 25th anniversary. First, as a preliminary matter, I would like to ask unanimous consent that, let's see, who do we have? I guess they're not here. Don't have to do that.
The answer is yes.
As a fellow Gulf War veteran, I have invited them. Unfortunately, they're not here. Let's see, we don't do that. This hearing will examine VA's treatment of and current health outcomes for veterans suffering from Gulf War illness. The hearing will focus largely on the issues that have arisen since our last hearing on Gulf War illness on March 13th, 2013, and specifically review VA's efforts to improve treatment and outcomes. This hearing marks the 25th anniversary of the Persian Gulf War, a conflict of swift intensity and short duration with what could be the lowest incident of post-traumatic stress disorder of any American war, according to some reports, including VA's own National Center for Post-Traumatic Stress Disorder. Unfortunately, this anniversary also marks numerous problems, some of which haven't improved since our hearing on Gulf War illness 3 years ago. I'm deeply concerned about how VA continues to characterize Gulf War illness as a mental disorder, as evident in its current clinical guidelines. I am perplexed that these same clinical guidelines are based in part on research that the Institute of Medicine has warned is potentially biased or influenced by pharmaceutical manufacturers. I'm also frustrated by the fact that VA is prescribing psychotropic drugs for not only Gulf War illness, but apparently also for instances of traumatic brain injury and post-traumatic stress. And I wonder about a possible connection between drug manufacturers and their sponsored studies and the high rate of prescription drugs being dumped on veterans with Gulf War illness. My concerns regarding VA's overuse of drugs are well-founded, given this committee's hearing last June that revealed VA administrators acknowledging the practice of overprescribing medication and turning veterans into drug addicts. VA has previously testified that Gulf War illness is not a mental malady, and its own training course states that it, quote, cannot be ascribed to any known psychiatric disorder, somatoform disorder, PTSD, or depression, unquote. Even so, VA continues to treat veterans as if Gulf War illness was a psychiatric problem, and that is an affront to those who have real physical ailments due to their service. I find it hard to believe cardiovascular disease, the physical scarring of lungs, central sleep apnea, head trauma, cataracts, and a variety of cancers are the manifestations of psychosomatic or psychiatric issues. If it could be as simple as a veteran thinking such things exist and then they disappear, I would simply think, VA is an organization truly capable of caring for veterans, and all of the department's continued failures would simply be resolved. What is even more frustrating is that the Institute of Medicine is apparently recommending no more Gulf War illness research be conducted, and that makes no sense whatsoever. But then again, VA has published so few recent studies that this seems part and parcel of business as usual. Gulf War veterans, myself among them, are tired of hearing the same rhetoric from the VA. Quite frankly, I have had enough of VA telling me one thing and doing the exact opposite. The fact that very little, if anything, has changed in the 3 years since we last held a hearing on VA's treatment of Gulf War illness is not only completely unacceptable, it is infuriating. I look forward to a spirited discussion on this important issue. With that, I yield to Ranking Member Custer for any opening remarks that she may have.
Thank you, Chairman Kaufman, and thank you for your service in the Gulf War. We're all grateful for that. Sunday marks the 25th anniversary of the end of Operation Desert Storm, and over the course of this quarter century, many veterans who served in that conflict have suffered from symptoms that are not readily identifiable or well understood. In fact, nearly 30% of Gulf War veterans suffer from Gulf War illness. These veterans still struggle to receive accurate diagnoses for their symptoms and access to needed health care. The veterans struggle to get effective treatment for their conditions, and for too many years, veterans suffering from Gulf War illness have been told it's all in your head. I think we can all agree today that Gulf War illness is not psychosomatic. Gulf War illness is a chronic, often painful, and sometimes debilitating disease, and our veterans deserve access to VA care and the most effective treatments for their illnesses and injuries. I'm concerned that recent findings from the Institute of Medicine may have been interpreted by some to mean that veterans should only receive mental health treatment for Gulf War illness. I'm also concerned that recent research findings may be interpreted to deny Gulf War veterans and all veterans suffering from ill-defined conditions access to VA health care and effective treatments. I wish to hear from all of our witnesses today so that we may begin to better understand the conclusions and recommendations of the researchers and experts in this field. It's so very important that we develop clear goals to ensure that our veterans receive access to health care, both for mental health and physical health symptoms, and the most effective treatment for their service-connected injuries and illnesses. We know that veterans of the Iraq and Afghanistan wars are also coming to VA hospitals in need of treatment for their symptoms, sometimes symptoms that are similar to those suffered by Gulf War veterans. That's why it's vital that the research continues so that we will best understand the very best treatments and continue to explore issues relating to causation in order to protect the health of our service members going forward. I believe it's incumbent upon us to learn as much as we can about what our nation is asking from our service members and their families when they volunteer and raise their right hand. We must recognize and be prepared to address the costs of that service and use our best efforts to ensure that our veterans are made whole again after returning home. And here I might just add that the chairman and I spent time together over Thanksgiving in Afghanistan, and one of the concerns is if we don't understand the causation behind the Gulf War syndrome and exposure to toxins or other trauma, psychological injury, PTSD, TBI, how this is all coming together, we're not going to have an understanding of putting our troops currently in harm's way in Iraq and Afghanistan. So I feel very strongly that we need to continue to investigate causation while we move forward with treatment for the veterans that have already been exposed. So thank you, and I yield back.
Thank you, Ranking Member Custer. We are now joined by United States Representative Jeff Denham from the state of California, a Gulf War veteran. Is there, I ask unanimous approval for Mr. Denham to be able to participate in this hearing?
Absolutely. Welcome, Mr. Denham.
So ordered. Thank you, Ranking Member Custer. I ask that all members waive their opening remarks as per this committee's custom. With that, I invite the first and only panel to the witness table, and you are currently seated. On that panel for the Department of Veterans Affairs, we have Dr. Carolyn Clancy, Deputy Under Secretary for Health for Organizational Excellence. She is accompanied by Dr. Stephen Hunt, Director of VA's Post-Deployment Integrated Care Initiative, U.S. Department of Veterans Affairs, and Dr. Victor Klasinski, I believe. I got that wrong. Senior Program Manager for VA's Gulf War Veterans Illnesses Research at VA. Also on the panel, we have Dr. Deborah Corey Slechta, Professor of Environmental Medicine, Pediatrics and Public Health Sciences, and Acting Chair of the Department of Environmental Medicine at the University of Rochester School of Medicine, who will be testifying in her capacity as Chair on the Committee on Gulf War and Health of the Institute of Medicine. Dr. Roberta F. White, Chair of the Department of Environmental Health at Boston University School of Public Health, who is accompanied by Mr. James H. Benz, Gulf War researcher and former chairman of the Research Advisory Committee on Gulf War Veterans Illnesses, and Mr. Anthony Hardy, Gulf War veteran and director of Veterans for Common Sense, who is accompanied by Mr. David K. Winnett, the second Gulf War veteran. I ask the witnesses to please stand and raise your right hand. Do you solemnly swear under penalty of perjury that the testimony you are about to provide is the truth, the whole truth, and nothing but the truth? Very well. Sit down. Please be seated and let the record reflect that all witnesses have answered in the affirmative. Dr. Clancy, you are now recognized for 5 minutes.
Thank you. Good afternoon, Chairman Kaufman, Ranking Member Custer, members of the subcommittee, Representative Denham. I'm accompanied today by Dr. Stephen Hunt, Director of our Post-Deployment Integrated Care Initiative. As Deputy Undersecretary for Organizational Excellence and an internist, my background has been conducting and supporting research to improve patient care and inform public policy for much of my career. So I know how important it is to get the science right and assure you that VA is taking every step possible to advance research, clinical care, and education on Gulf War illness. Since our last hearing in 2013, VA has funded or conducted over 60 studies. Funding for Gulf War research has increased steadily from $5.6 million in 2011 to over $14 million this year, and that's a very conservative estimate. For example, a study funded this past June is a randomized trial of something called CoQ10, thought to change subcellular function in a way that could help treat the effects of Gulf War illness. Other studies evaluate the effectiveness of a broad range of treatments for musculoskeletal pain, fatigue, and cognitive issues using exercise programs, magnetic stimulation, and other innovative approaches. So as we look for promising interventions through research, VA is also working diligently to treat those veterans that are now suffering from Gulf War illness. From 2000 to 2015, the percentage of Gulf War veterans enrolled in our system has increased from 13% to about 33%. We offer continuing evaluation and treatment to the over 700,000 men and women who served in Operations Desert Shield and Desert Storm. We have centers of excellence, 3 of them called War-Related Injury and Illness Study Centers, or RISCs, and we want to express our appreciation to the Congress for these, which are charged with conducting cutting-edge research, clinical education, and providing specialized care for Gulf War veterans with complex, chronic, unexplained, or very difficult to diagnose conditions. And demand for their services, no surprise, as the number of Gulf War veterans has increased, demand for these services has also increased. In addition, a total of 145,000 Gulf War veterans have undergone a Gulf War registry exam, allowing their health concerns to be evaluated by VA physicians and enabling them to be referred for additional care. We first learned from Gulf War veterans just how important it is to integrate all the care and services that veterans need, and to integrate and organize that around the veteran and the veteran's needs. And in fact, that became an organizing principle for much of our system and team-based primary care. And in fact, that has helped us to organize our referrals to community providers when necessary as well. We know that many Gulf War veterans are affected by a debilitating cluster of medically unexplained chronic symptoms that can include fatigue, headaches, joint pain, indigestion, insomnia, dizziness, respiratory disease, memory problems. And the chronic multi-symptom illness we see so often in Gulf War veterans is clearly not a psychological condition, so I want to be very clear on that. We're committed to ensuring our research, clinical care, and education takes into account all of the factors that are relevant to returning that veteran to the highest level of function. We have aggressively pursued and fast-tracked studies in ways we can meet the research and treatment needs for all veterans that have been affected by environmental exposures. So that research serves two purposes. One is to improve clinical care that we're providing now for those enrolled in our system, and the other is as the basis for presumptions or other benefits. Our philosophy has been to come down on the side of the veteran when the science supports it, and as you've seen, we have made our policies more liberal for C-123 crews and are now adding new presumptives for veterans who served at Camp Lejeune. In addition, we've been working with Ron Brown at the National Gulf War Resource Center to address a number of concerns and possible presumptions for Gulf War veterans. Going forward, we recognize that while we've learned a lot, we need and value the ongoing feedback and input from our stakeholders, this committee, of course, the Research Advisory Committee, the Veteran Service Organizations, and very importantly, Gulf War veterans themselves. As we conduct an in-depth review of the most recent Institute of Medicine report, we're going to include 2 full days to receive public comments and feedback from our stakeholders and partners to assure that VA's priorities are informed by veterans and stakeholders. You know, vigorous disagreements in science are part of the landscape, and we welcome that at all times. That's what moves science forward, and we're committed to hearing from all sides. That concludes my testimony. My colleague and I look forward to answering your questions and that you or the committee may have.
Thank you, Dr. Clancy. Dr. Corey Slechta, you are now recognized for 5 minutes.
I am Deborah Corey Slechta, Professor of Environmental Medicine, Pediatrics, and Public Health Sciences, and Acting Chair of the Department of Environmental Medicine at the University of Rochester School of Medicine. I served as Chair of the Committee on Gulf War and Health Volume 10, which was released February 11th of this year. The committee that I was chaired was asked to review and evaluate the scientific and medical literature regarding associations between illness and exposure to toxic agents, environmental or wartime hazards, or preventive medicines or vaccines associated with Gulf War service, paying particular attention to neurological disorders, including Parkinson's, MS, ALS, and migraines, to cancer, particularly brain cancer and lung cancer, and chronic multi-symptom illness, also known as Gulf War illness. Volume 10 updates 2 earlier Gulf War and health reports, Volume 4 in 2006 and Volume 8 that was published in 2010. The committee made recommendations for future research on Gulf War veterans, and I would note that this committee was composed of experts in neurology, epidemiology, pain, psychiatry, neurocognitive disorders, environmental health, and toxicology, and they were clinicians and researchers, none of whom received funding from Gulf War illness research programs. Volume 10 basically followed the approach used by earlier committees. We held 2 public sessions at which we heard from representatives of the VA, from Gulf War veterans and veteran service organizations, Gulf War researchers, and representatives of the VA Research Advisory Committee. We did not address policy issues such as service connection, compensation, or the cause of or treatment for Gulf War illness. We conducted an extensive literature search, reviewed the volumes 4 and 8 conclusions, as well as their primary and secondary studies. We also looked at animal toxicology, neuroimaging, and genetics. We tried to be totally inclusive. We divided our studies into primary studies. They had to be published in peer-reviewed journals or demonstrating reporting rigorous methods, including information on a persistent, not acute health outcomes, used appropriate laboratory testing if applicable, and had a study population that was generalizable to and representative of the Gulf War population. Secondary studies were those studies that didn't meet all of these criteria. Many of the secondary studies relied on self-reports of diagnoses, rather than examination by a health professional or a medical record review. We used the same categories of association that were used in the previous volumes. I won't go through all those. Suffice it to say, we have a sufficient evidence of a causal relationship, sufficient evidence of an association, limited suggestive evidence of an association, inadequate, insufficient evidence, or limited suggestive evidence of no association. The committee found that in spite of many millions of dollars that have been spent on researching the health of Gulf War veterans, there has been little substantial progress in our understanding of their health, particularly of Gulf War illness. The Volume 10 committee found little evidence to actually warrant changes to the Volume 8 conclusions. We fundamentally agree with the Volume 8 conclusions regarding the strength of the associations between deployment to the Gulf War and adverse health outcomes. Veterans who were deployed to the Gulf War have an increased risk for many long-term health conditions, including PTSD, Gulf War illness, chronic fatigue syndrome, functional GI conditions, generalized anxiety disorder, depression, and substance abuse. And in the testimony that I've provided you, you can see our categories of association with different health effects summarized in box 1. As requested in its statement of tasks, the committee had additional discussions pertaining to Gulf War illness, specifically neurologic conditions and lung and brain cancer, as well as Gulf War illness itself. So Gulf War illness, of course, is the signature adverse health outcome of having served in the Persian Gulf. Multiple studies have found that some Gulf War veterans, regardless of their country of origin and their different deployment-related exposures, have persistent, debilitating, and varying symptoms of Gulf War illness. In spite of over 2 decades of research to define, diagnose, and treat Gulf War illness, little progress has actually been made in elucidating the pathophysiological mechanisms that underlie it, the exposures that may have caused it, or the treatments that are generally effective for it. Gulf War illness is not an easily diagnosed condition. The committee concluded it is not a psychosomatic illness, but it does, like almost every disease and disorder that we know of, present with diverse symptoms, many of which overlap with other health conditions such as chronic fatigue, neurodegenerative disorders, musculoskeletal. The committee concluded that though the existence of an animal model would be advantageous for identifying and evaluating treatment strategies, we caution that developing an animal model is really precluded by the absence of any objective measures of chemical and non-chemical exposures during Gulf War service, let alone the frequency, duration, or dose of those exposures, or the highly likely interactive effects of multiple exposures, about which we know almost nothing. We found it unlikely that a single definitive causal agent will be identified in the many years after the war. Furthermore, many of the Gulf War studies have excluded the psychological aspects of the condition with regard to both diagnosis and treatment, although veterans report symptoms such as chronic pain and sleep disturbances that may be amenable to psychological therapies alone or in conjunction with other treatments. We found little new information pertaining to MS, Parkinson's, or Alzheimer's disease or migraines. We did recommend that ALS is the only neurologic disease for which we did find limited suggestive evidence for an association, but because the time frame has been too short to really look at this, we recommended additional follow-up for prevalence of ALS in this population. Similarly, we found evidence for brain cancer to be inadequate, insufficient, and we found no statistically significant increase in the current risk of brain cancer in deployed Gulf War veterans compared to non-deployed counterparts, a finding that's actually mirrored in another recent IOM study. With regard to lung cancer, in the 10 to 15 years follow-up that have been reported may not, again, like ALS, have been an adequate time frame to really see whether, in fact,
Dr.
there is
Flechter, I'm
an
going to have to ask you to move along,
you.
simply because you're at 7 minutes right now.
Sorry. Okay. In conclusion, what is striking about this and prior Gulf War and Health Committee's finding is that I'll just skip to the end. Let me just quickly go through these. Recognize the connections and complex relations between brain and physical functioning and do not exclude any aspect of Gulf War illness with respect to improving its diagnosis and treatment. The Department of Veterans Affairs and Department of Defense should develop a joint and cohesive strategy on incorporating emerging diagnostic technologies, personalized approaches to medical care into sufficiently powered future research to inform the studies. I would also say, in regards to what I heard before, the importance of biomonitoring of exposures before, during, and after military. The involvement in the military is going to be critical to ultimately providing any associations to chemical exposures. There need to be follow-up for neurodegenerative diseases that have long latencies and are associated with aging, as I mentioned before. And let's see. Without definitive and verifiable individual veteran exposure information, further studies to determine cause and effect relationship between Gulf War chemical exposures and health conditions in Gulf War veterans should not be undertaken. We did come up with a list of outcomes where we believe that there's sufficient data already to suggest an association, that we don't need to do more studies to re-demonstrate those. Some where 25 years after the war, we're not likely to see anything, and so some of those kinds of health conditions didn't warrant follow-up, as well as some that we said had a longer latency and still needed to be considered. And finally, one other thing was to begin to break out sex-specific and race ethnicity-specific health information, which may be important not only to understanding different vulnerabilities by sex and race, but also in terms of understanding mechanisms and treatment for disease. Thank you, and I'm sorry for going over time.
Thank you, Dr. Slechta. Dr. White, you are now recognized for 5 minutes.
Chairman Kaufman, Ranking Member Custon, and members of the House Veterans Affairs Subcommittee on Oversight and Investigations. It's the 25th anniversary of the Gulf War. Our veterans won this conflict in less than a week. However, concern remains high that the troops who produced this victory are and will remain ill, without legitimate acknowledgement of their health problems and associated disabilities, and without effective treatment options now or in the future. Despite decades of scientific evidence to the contrary, the VA and the Institute of Medicine have recently produced documents that minimize the poor health of these veterans by terming their illnesses to be functional, a medical term for psychiatric illness. This injustice is then compounded by a VA treatment guideline that suggests ineffective, unproven, palliative, and potentially harmful treatments for Gulf War illness that focus on psychiatric symptomatology. I speak as a clinician scientist who has worked with ill Gulf War veterans clinically and in research for over 20 years. My work on Gulf War illness is part of a 35-year career in which I have studied the effects of exposures to neurotoxic chemicals in adults and children. For 8 years, until last fall, I served as scientific director of the Research Advisory Committee on Gulf War Veterans Illnesses. It has been known since a year or two after their return from the Gulf that a subset of Gulf War veterans was experiencing debilitating physical illness. Research beginning at that time and continuing to the present has produced a consensus of scientific knowledge about this illness that I will summarize briefly. First, dozens of studies in multiple countries reveal that approximately 30% of the 1991 Gulf War veteran population suffers from a characteristic pattern of physical health symptoms that we call Gulf War illness. This pattern of health symptoms is not seen in veterans of other conflicts. Second, illness is not the result of stress or other psychiatric factors. Rates of post-traumatic stress disorder are typically less than 10%. Furthermore, rates of Gulf War illness are not significantly higher in Gulf War veterans with psychiatric diagnoses. Third, Gulf War illness is associated with exposures to chemicals present in theater, especially pesticides and pyridostigmine bromide, and possibly nerve gas agents, sarin, and particulates from the oil well fires. Fourth, effective treatments for Gulf War illness and other disorders that are induced by chemical exposures that damage the brain do not exist at present. However, recent research has identified treatment options that target specific nervous system and immunological mechanisms of Gulf War illness. These treatments are now being piloted. Despite these treatment advances, new recommendations for treatment of Gulf War illness from VA emphasize immediate referral for mental health evaluation. In addition, cognitive behavioral therapy is suggested. This is a palliative treatment at best and has been shown to be minimally effective in VA research on Gulf War veterans. Even worse, the treatment guidelines recommend 11 drugs to treat Gulf War illness, 10 of them psychiatric. All 11 drugs are noted in the guidelines to have significant adverse side effects, including suicidal ideation. And these medications have not been studied with regard to their effectiveness in the treatment of Gulf War illness. The recent Volume 10 Institute of Medicine report further contributes to this situation by minimizing the health problems of Gulf War veterans and again placing a psychiatric cast on them. Although the Volume 10 IOM report states that the science has not changed since the Volume 8 report, its conclusions fly in the face of the scientific consensus on Gulf War illness that I have described. The Volume 8 report concluded that Gulf War illness cannot be reliably ascribed to any known psychiatric disorder. The Volume 10 distorts and disavows this conclusion by saying that the illness cannot be fully explained by any psychiatric disorder. Unlike prior reports that support mechanistic scientific research on Gulf War illness, Volume 10 suggests that it is time research efforts focus on mind-body connectedness, and that further research to determine the relationships between Gulf War exposures and health conditions in Gulf War veterans should not be undertaken. To recommend stopping research into the mechanisms underlying the disease, just as research into these mechanisms has begun to make real progress, is shockingly short-sighted. And to suggest that psychiatric research has been neglected could not be farther from the truth. During the first 15 years after the war, federal Gulf War research focused mainly on psychiatric issues with negative results. It is unthinkable that the scientific progress now being made should be halted by a return to the psychogenic era. Thank you.
Thank you, Dr. White. Mr. Hardy, you're now recognized for 5 minutes.
Thank you, Mr. Chairman and Ranking Member and members of this committee for your service, for this hearing, and for the opportunity to speak with you today. This is just a brief overview. There are more details on my written submission. I really hope that you'll take the time to read the few pages of it. I'm Anthony Hardy, a 1991 Gulf War and Somalia veteran. I'm Director of Veterans for Common Sense, and while I've provided testimony on several occasions, today is especially notable. Exactly 25 years ago tonight, we launched the ground war of Operation Desert Storm and successfully liberated Kuwait. Tonight, I would like for us to remember and honor the nearly 300 warriors who made the ultimate sacrifice. I would also like us to remember and honor our Gulf War veterans, including those in this room and watching, and our leaders who led us to decisive military victory. Our war was relatively short, but you've heard our stories before, and with 1/4 to 1/3 of us coming home with serious and debilitating health issues now known as Gulf War illness, we faced a new battle, a long war to obtain health care, effective health care and VA assistance from entrenched government officials who seemed intent on minimization and denial at every turn. Even through to today, VA describes our toxic wounds as medically unexplained. Finally, in 1998, we won enactment of 2 landmark bills for Gulf War veterans to guarantee health care and benefits based on research. Yet from the beginning, VA officials circumvented their implementation. That leads us to today. The Institute of Medicine recently released its final report in the Gulf War and Health series under VA contract as directed by the 1998 legislation. It's highly problematic. As I walked through the airport on my way home from the report's release, the weight of the bag with nearly 2 decades of these IOM reports was heavy on my shoulder, and I want to show that weight. My heart was even heavier because their collective weight has added little to nothing for Gulf War veterans. It has not associated any of our exposures with their health issues and has added little towards the development of effective evidence-based treatments for Gulf War illness. The real weight is being borne by Gulf War veterans who are suffering from Gulf War illness. This new report recommends no further research using animal models of Gulf War toxic exposures, which amounts to rolling up the sidewalk on this promising avenue of Gulf War illness research, just when it's beginning to unravel the underlying mechanisms of Gulf War illness and point to treatment targets. And this now affects not just non-VA CDMRP research, but VA research as well. In one section, it points out that the VA hasn't reported critical data, but in another, recommends ending research on a long list of health conditions, despite long histories of them in Gulf War veterans, not reported by VA. While acknowledging Gulf War illness as the 1991 Gulf War signature condition, there were no Gulf War illness researchers on this panel. It recommends a shift to brain-body interconnectedness that departs from the scientific opinion that effective treatments, cures, and it is hoped preventions can likely be found. Instead, this is more like the 1990s when VA and DoD officials, some of whom were involved in writing this report, denied Gulf War veterans toxic exposures, denied benefits, and failed to develop treatments or preventions. And now VA and DoD have developed a clinical practice guideline that goes back to the very darkest days of the 1990s, authored by some of these same old names and ideas. Despite VA public statements to the contrary, including to this committee, this guide for VA and DoD doctors is filled with references to psychosomatic and somatoform disorders, 52 times to be exact. Its primary recommendations for Gulf War illness are cognitive behavioral therapy, or talk therapy, exercise, and psychotropic drugs. Suicidal ideation is listed in the guide as a notable adverse effect for every single one of those medications at a time when we have a suicide crisis amongst veterans. VA has active Gulf War veteran studies on CBT and exercise, but somehow still recommends them as evidence-based in this definitive guide. 25 years after our war, VA has circumvented most of the aims of the 1998 laws intended to help us. In addition to the above, VA lost its registry for Gulf War spouses and children, ignored and then gutted the Gulf War Research Advisory Committee, misleads Congress in its reports to Congress, found no link between Gulf War exposures in Congress, including in these manuals, identified almost no new presumptives. If we measure VA's success by how it's improved Gulf War veterans' health 25 years after the war, VA still has not a single evidence-based treatment for Gulf War illness. Others among us have died of ALS, brain cancer, and suicide, and only since the Congressionally Directed Medical Research Program was enacted, and through the support of many on this committee, has VA even begun to look at developing treatments. And while there is real research progress, most of it is being made outside of and in spite of VA in the CDMRP, thanks to many of your support. 25 years later, 1/4 to 1/3 of us Gulf War veterans continue to struggle with the health and life effects of Gulf War illness. We must not continue to allow VA and DoD to substitute risk communication for evidence-based health care, psychosomatic drugs for treatment-focused research, spin for substance, or don't look, don't find for the objective collection, analysis, and reporting of deployment health outcomes. The letter, the spirit, and the intent of the 1998 Persian Gulf War laws that we fought so hard to win have yet to be achieved. And again, this is just a brief overview. On this 25th anniversary of the Gulf War, our Gulf War veterans deserve the very best that modern science and the U.S. government can offer to improve their health and lives. Mr. Chairman, as one of our Gulf War veterans and members of this powerful committee, please join together and with your colleagues on both sides of the aisle and in both houses and help fix these serious issues once and for all. My fellow Gulf War veteran David Winnett and I look forward to your questions. Thank you again for this opportunity.
Thank you for your testimony, Mr. Hardy. Mr. Hardy, do you recall, and so when we talk about, first of all, the duration of the war, that there were troops on the ground in August of 1990, and then the fact is that the air campaign, I think, started on January 27th, ground war started on February 24th, but there was certainly contact prior on the ground side with Iraqi forces. But there was the term, was it blow in place, I think is a combat engineering term, and that there were chemical munitions
Yes, sir.
that were blown in place that the Department of Defense denied. Do you remember what the name of the location was, primary location was, and the date?
Yes,
that
Mr.
occurred?
Chairman, it was in early March of 1991 after the end of the war. It was at a place called Camisea, and candidly, it was the only one of the incidents that we Gulf War veterans were ever able to get DoD to admit to. There were many others.
But it took how long? Was it 5 years? I can't remember. What was the time length that it took? Because there was a cover-up, quite frankly.
Yes.
Because the page out of General Schwarzkopf's log was missing on that day. All other records were destroyed intentionally. They said they were, I can't remember, accidentally destroyed, but they were destroyed nonetheless. So where there was no fingerprints, and the statement by the Department of Defense was that no U.S. troops were exposed to any chemical munitions, chemical weapons. We know that's not true today. Nobody faced disciplinary consequences for lying. And then so the research never took that into account because the Department of Defense denied that. How long did it take the Department of Defense to finally acknowledge that U.S. troops had been exposed?
Well, Mr. Chairman, my understanding, my recollection, that was about 5 years. It
About
was
5 years.
About 1996. And again, to emphasize, as you just said, that was the only incident that we were successfully able to get DOD to acknowledge. And all that information, that evidence came from Freedom of Information Act requests from a large number of veteran advocates out there who did an incredible job of digging up and finding out what DOD and VA and the CIA did not want to be
What was
admitted.
the name of those pills we had to take, and they were,
Pyridostigmine bromide, sir.
and they were not FDA approved, is that correct?
That's correct. My understanding, though, is that DOD has recently approved them now for use, and that's extremely concerning, given the health effects that me and the men in my unit had. I can't understand how that's even possible.
And what was the purpose? Was that for biological, or what was that?
So it was an anti-nerve agent prophylaxis.
Nerve
It was-
agent, okay.
It's in order to help to improve the survivability if we were hit with one particular nerve agent, although now research by Dr. White and others has shown that this drug, in combination with other chemicals, is extremely problematic and for our health, and causes Gulf War illness-like symptoms in laboratory animals, the kind of research that the IOM report recommends ending.
And then Saddam Hussein had blown a lot of the oil well heads to obscure, I think, his own movement or positions of his troops. And then, of course, through our own bombing efforts, probably destroyed the balance to where there were days, I remember, where a wall of black smoke would be coming at you, and you were literally engulfed in that oil well fire, the smoke emanating from those oil well fires for very long periods of time. Do you feel that that's been adequately researched in terms of what the health effects of that are?
Mr. Chairman, I don't feel that any of it has been adequately researched. I think the VA has done an atrocious job. I think that there's a long list of conditions in the 1998 laws that were supposed to be, VA was supposed to contract with IOM for. Many of those were never researched, including low levels of mustard, which we know is in the January 19th plumes drifting over the troops. The studies of sarin failed to connect illness in animals exposed to sarin with human health outcomes. That's extremely problematic. And of course, these days, we're not putting human beings into a gas chamber, exposing them to deadly nerve agent like sarin. But so there's this impossible standard that has prevented the 1998 laws from ever being achieved. Again, I don't believe any of the substances have been adequately researched or in the right ways.
Have you, this is my last question, have you uncovered at all why that the command, senior leaders there chose to destroy those chemical weapons there as opposed to properly dispose of them?
That's a more complicated question, sir. I don't have, I have my own beliefs,
Okay.
but I don't have a good explanation. I do say that it's extraordinarily disappointing, particularly that those logs, General Schwarzkopf's logs, disappeared. I served in an intelligence role in the 1991 Gulf War and kept logs of my own, which have never been able to have been found. My entire unit's medical records have, our medical records disappeared. It took a year for our personnel records to show back up as well. And there were a series of chemical incidents, including one nearby to where I was located, where we were, the messages that I was logging were that chemical warfare agents were detected, were confirmed again, and then suddenly it all went away. And the evidence that Gulf War veterans uncovered through Freedom of Information Act requests showed that over and over and over again, DOD, the CIA, and the VA have all fought all of that across the board. And it's very clear to all of us. We came back home sick. 25 years later, we've got a stack of volumes. That hasn't helped us. And we need to do better.
Mr. Hardy, thank you so much for your testimony. Ms. Custer, you are now recognized.
Thank you, Mr. Chair, and thank you, Mr. Hardy, for your service, and Dr. White for your research, and to the whole panel for being with us today. I'm just thinking of my own personal experience, not in wartime, but I had an illness that was connected with ingestion of volcanic ash, and I was very sick for a very long time. And so my empathy is with you and the veterans in terms of a substance like that you don't, you know, I learned later that that's really ground glass, and when it gets into your lungs, you do get sick. But it was that same feeling of the cloud coming towards you, and the helplessness of, you know, not being able to protect yourself. So my goal here is twofold. One is to make sure that we have a sufficient understanding to help the veterans from the Gulf War era. And number two, and equally importantly for me, that we have an understanding to protect our service members who are currently serving abroad. And so my question, and I've just put this out to Mr. Hardy and Dr. White, but if anyone else wants to weigh in, have we, I understand your frustration, and I'm just wondering, have we made any progress? Are there individual instances? Are there anecdotal stories of treatments that have been effective that could be more widely used? Let's start with that.
Maybe if I will first, and then Dr. White will have probably other things to add as well. But there is hope through the efforts of many here in this room, including, thank you, Dr. Rowe and Mr. Walls, for your leadership with the congressionally directed medical research program, and for many of you who have signed on in support of that program. It was created in FY 2006 and has shown great progress, but again, outside of and in spite of the VA. Which is now doing some good things, thanks to the work of Dr. Kalasinski, but has a long ways to go. About a third of the studies funded through the program are testing actual treatments that might help the health and lives of ill Gulf War veterans. The other 2/3 are studies that are aimed at Gulf War illness's underlying mechanisms. They include critically important animal studies that test exposures and measure health outcomes. Again, the kinds of things that are now threatened by this IOM report. They identify treatment targets. They test treatments. There are three treatments. Again, much of this is still in the pipeline, but there are 3 that have been shown to be effective in limited numbers as well. Coenzyme Q10, carnosine, and acupuncture for pain. I take CoQ10 every day. It helps me a great deal. It's not a cure, but it certainly makes a difference. I've heard the same from other Gulf War veterans. I'm pleased to hear that now we have this study coming from that will advance it. But again, it's not a cure. I take it every day, and I can tell you that but we're making the progress now through this program, and we hope that VA would finally get on board with making the systemic changes that need to happen, including in its badly broken Office of Public Health.
So one of the things we're going to be doing a regional hearing of this subcommittee, actually coming to New Hampshire to talk about opiate use and some interesting research that's going on in White River Junction, VA, to bring down the use of opiates using alternative remedies, acupuncture, mindfulness, some of the things that you've mentioned. Because I do believe in that mind-body connection, and I don't mean to diminish anything about it. I know that there are certainly illnesses, thyroid illnesses, that type of thing, where it is so closely connected. So I think it's worth exploring these other treatments, and I guess, and because I agree with you that just throwing pills at it, throwing psychotropic medication that have these downsides with certainly suicidal ideation, et cetera. But just going forward, I'd love to talk with you all about, we're going to be looking hopefully at legislation about best practices in the VA on pain management. Maybe there's a way to bring in some of this research that has gone forward. And Dr. White, I have a very brief time left, but if you have any comment.
I would say that there's a number of lines of treatment approaches that have been supported by CDMRP and more recently VA through our recommendations and work with them on the Research Advisory Committee. Some are aimed at symptoms, brain activation, improving general health and well-being. Obviously, when chemicals affect the brain, they affect how you feel as well as how you think and your immune system, and it is a whole body thing. I think what we're trying to say is that there is physical damage to the brain that is causing emotional as well as cognitive and other symptoms, and you need to approach the whole package. One thing that I think is really wonderful about the support we've gotten for the CDMRP programs, and I'm on the integration panel for that, is that we are now working on therapies and trying to fund therapies that get to the neuroinflammatory and mitochondrial basis of this disease. If we can find treatments that go after the neuroinflammation, that go after the mitochondrial damage, that go after some of the mechanistic underlying pathophysiology of this illness, we will not only help the Gulf War veterans, we'll help other people with exposures in the whole world.
Right.
And these kinds of chemical exposures are very hard to treat, as you know from your own illness. So I think that there's so much promise in the mechanistic-based treatment, as well as the symptomatically focused treatment. I would hate to see that lost. We're finally getting to mechanism, and we were not anywhere close to that 10 years ago.
Yeah, no, I need to yield back, but I agree, and the other half of my question, we won't get into it here, but I am extremely concerned that we get upstream on understanding the exposure, because obviously, you know, I don't have to tell my colleagues that war is a dirty business, but at least we can do our best to protect our troops from smoke and inhalation and that toxic exposures. So thank you, Mr. Chair, for your indulgence.
Thank you, Ranking Member Custer. Dr. Rowe, you're now recognized for 5 minutes.
Thank you, Mr. Chairman, and for the group here. I don't know whether you know or not, but I've sponsored a bill called the Desert Storm Desert Shield War Memorial Act, and we're in the process of, hopefully, I'm meeting with Scott Stump in just a little while this week, I think sometime this week, to talk about how we raise the funds for that. But we wanted to do that while it was still on everyone's mind and people forgot about it. I think the question that I have, and as a scientist, and it makes it difficult, when you don't know the etiology of a disease, it's very difficult. You end up treating symptoms, and they may vary. And I've found that one of the great things that used to really bother me when I was in practice was if we didn't know what was wrong with you, we either said it was a virus or you were nervous. I mean, that's basically what you're doing. And I hope we're not doing that here. I don't think so. I think good, honest people have looked at the data. I think it's very, very hard to assimilate this. And a question I have for anybody on the panel, have we looked at the oil workers who put the fires out? Have we looked at the cohorts there in Kuwait right now? There are people that still live in Kuwait that were there. Did they have these symptoms? When we looked at the cohort who were in the service but weren't deployed versus the ones who did, and I think the Institute of Medicine did that. I think that's the cohort they looked at. You have a built-in group of people right there in Kuwait who were there during the war and Iraq? And has anyone who served in the current conflict in Iraq, now that we've been out of there for a while, have they had these symptoms? A lot of questions.
Well, to answer some of your questions, there have been studies on subgroups of people within the Gulf theater who had very specific kinds of exposures. So there's a bunch of research out on the pesticide applicators, and we know a lot about what pesticides they were exposed to, how much, what it did to their health. There is a study that's being done at Harvard that I'm participating in on the Kuwaiti population. The people that were there then do have increased symptoms. We're trying to figure out what it means because the surveys that they used and so on didn't exactly address it the way we would address Gulf War illness. The other point I want to make is that the exposure scenario in the Gulf War theater was very complex, and comparing deployed to undeployed veterans does not always tell you what happened to people who were in specific places with specific kinds of high exposures. So the standard that we tried to ask for on the RAC and in the Cortex paper that I just wrote is looking at people within who were deployed to the Gulf, who were exposed versus who were not exposed and who were in certain locations.
Well, you're going to say, because I know probably the chairman, when you're in the military, sometimes you don't know where you are. I know that I have been deployed in places I didn't know where I was. And,
Yes.
and matter of fact, I've asked that question, where are we? I mean, so are you able to pinpoint, that's a great point you made. Can you do a sort of a spotogram where these folks were, because you're right, being deployed 100 miles up here might not be the same as being deployed next to a chemical burn.
Yes.
No question, that's true.
So where that data came from, and I used a lot of this data when I was head of an environmental hazard center that was funded by the VA, was we asked for data on what troops were where. And we got troop level data on locations in Gulf, and we used that for some of our research. That's how we knew who was in the area of the Comisia detonations and certain other things. So yes, those data are there. It took a lot of years to get it because it was in paper in a warehouse, but there are data on who was where, at least at the troop level.
At least that's where they think they were supposed to be.
Yes, because not every individual was where their unit was supposed to be either.
That you get, when you get shot at, you're not necessarily where you're supposed to be. You move from that place. So I guess what the last question, my time's about expired, but I thank all of you, because this is one of the most difficult epidemiologic issues I've ever looked at, because again, like in Ebola, we knew what caused Ebola. In other diseases like that, where there's a single agent, we know how that goes. We know exactly what an epidemic is going to do. We've followed them for centuries. We know what they're going to do. This is much more difficult because you haven't identified a single agent or multiple agents, or maybe there were one agent here and somebody else was over here. So, and did the treatment contribute to it? I mean, did giving the soldiers something to prevent it do anything? So I admire you for trying this. This is one of the most difficult epidemiologic studies I've ever seen. So I yield back.
The only thing I would say very briefly is, I mean, I think it's a particular challenge for a chronic, ongoing kind of condition, which is different than a sort of acute epidemic, the way that you've described. The other thing I would say is I don't think that we should discount the progress we've made. Cancer would be a perfect example, right, where we've learned a lot through brunt empiricism, because we didn't understand underlying etiology, but we tried a whole lot of different treatments first and eventually made a lot of progress.
Thank you, Dr. Rowe. Sergeant Major Waltz.
Thank you, Chairman, and I thank you all for being here. I think I'll dovetail on that, Dr. Clancy. First of all, thank you for the update on the STEP pain management plan. I think it's important information with the hearing that's going to be next week up in New Hampshire with Ms. Custer, that back in '07 this very issue was out there, and I think great strides were made, and I think you have much to add to the conversation, because this is not a VA issue of opioid use and pain. It is a societal issue. So I appreciate that update. And I think, going back to what you said, I do think you're right on that. I think much progress was made on some of these very difficult ones. Dr. Rowe clearly laid out the epidemiology and the challenge of this. My concern is, though, when do we make a decision that we've tried hard enough, or that we've reached that point? Because I think the frustration lies in this, that I think something's happening. And again, we have to have the data, but there's something happening. There's enough people reporting it. All of us are hearing this. And I just wondering, you have to make tough decisions about where funding sources go and where those types of things happen. I think there's a belief of many of us that this is going to be difficult, but we have a responsibility to keep going on it. How do you make a decision, you being the VA, if you can speak for that, how do you make a decision on how hard you push on a certain area or how much you do in the research?
So let me just say, having run a research agency for quite a few years at HHS, this is one of the toughest kinds of decisions to make, and it's really an investment question, right? Where do you place your bets in terms of getting to rapid answers and the kind of evidence that you want? And there's no biblically correct strategy in terms of rules to guide you. The one recommendation, the very top line recommendation, and I want to emphasize that we've not had a chance to go over this Institute of Medicine report. It's still, the ink is still drying, so to speak. It's actually a pre-publication version I think we're all looking at and so forth, and are looking forward to going over it with our Research Advisory Committee very, very carefully. But the notion that we would develop a cohesive, coherent plan with the Department of Defense, and frankly invite in others like the Harvard study that Dr. White referenced and so forth, to find out, to really push very hard on this question. This is a huge proportion of people who are deployed for these two operations, and we don't have any answers. We have some promising signals, and that's exciting. I think some additional genomic studies, as a paper that I'm looking at from Dr. White has pointed out, may help us even more. But that's not coming up with an answer for why are almost a third of these soldiers deployed struggling. So I think that this is going to be a tough answer to come up with and a tough strategy to come up with, but it's one that we'd be looking forward to giving you full answers on. The last thing I would say is the number I gave you is a very, very conservative estimate because it doesn't count our epidemiological studies. It doesn't count the investments we've made in registries, for example, the Gulf War Registry, the Burn Pits Registry, and so forth. And so we're investing more than that, but the question is, have we done enough? And I think the answer to that is no.
No, and I appreciate that, because I do think you've got on it, too, the broader issue. I think many of us who have followed the issues on Agent Orange, and there's Vietnam veterans sitting in this room that have pushed on this, they're concerned on the genetic defect issue of how many generations down the line, you know, beyond spina bifida, of what's happening to these children, what's happening to the grandchildren. That's going to come to this, the burn pit, the depleted uranium. So my question is, are we doing enough? I mean, shame on us if we're not learning that every generation has to come back and fight the fights on these things. Is now the time for a center of excellence on toxic wounds? Is this the time to do that? Does that make the difference where it brings the force of all of these issues under one? Because the thing I worry about is I don't want to pit Parkinson's research on Agent Orange exposure against Gulf War exposure. And I know you may tell me that's the choices we have to make, the hard ones. So I ask you, is the Center of Excellence the way to go to bring this under one in-house?
You know, it may be, and we would love to work with you on that, because no matter what we called it, because I agree with you about the X amount here, Y amount there, who's made the most noise recently, to be crass.
Yes, no, I think that's a true statement, though.
No matter how you cut it, it's going to have to be an entity that coordinates what we're doing with defense, with what's going on at HHS, and from a variety of other funders, which would be great, actually, but I think we can leverage all of that. We've recently been working with CDC's Agency for Toxic Substances and Diseases on the Camp Lejeune issue, and actually that was very, very productive.
And I think our issue, especially with these toxic wound exposures in battle, it differs from cancer in that the private sector is not investing as much in this because there's not it's a limited universe that's going to be treated by this. So once we treat them, which we need to do, and cure them, there's not a market for the product necessarily.
Exactly.
That may be crass too, but that's the reality of the economics. But no, I thank you all for that, and I think the commitment here is that something happened to these folks. It's real, and they deserve an answer and a treatment. So I yield back.
Thank you, Sergeant Major Waltz. Mr. Huelskamp?
Thank you, Mr. Chairman. I appreciate the topic of our hearing today. I'm hearing a lot of contradictory claims and concerns and maybe conclusions. I want to direct a couple questions to Dr. Hunt, who I don't think has had opportunity to participate today on question and answer. But based on the tenor of a relatively recent presentation you gave called A Model for Providing Services for Returning Combat Veterans, it's apparent that you and others in the VA believe Gulf War illness is a mental disorder. Is that correct?
That is not correct. I'm not sure where you got that information.
Did you not have a presentation entitled A Model for Providing Services for Returning Gulf War Veterans?
Presented where?
I don't have the place of presentation.
I don't believe that, and I have never said that, and I do, no.
Oh, so this wasn't your presentation, Matt?
It could be. I would have to look at it. I'm not sure.
Okay, well, I don't know. This is, you never made a presentation on a model providing services for returning Gulf War veterans?
I give presentations on that often. But I would like to see it because it certainly is a misinterpretation of what I believe and I suspect what I said.
So do you believe also, or otherwise, that psychiatric drugs are the best treatment for veterans with Gulf War illness?
I believe that medications should be used for conditions they're indicated for, and psychiatric medications are not indicated for Gulf War illness.
So
per se.
what kind of treatments would you suggest then?
I think 25 years ago, what was going on with me was I was starting to see people coming back in 92 and 93, coming back from the war. And the things that they were saying when they came back were not, I have Gulf syndrome or I have a mystery illness. What they were saying was, I'm not doing very well. I'm having a lot of trouble. Having trouble at home, work's not going well, can't do my PT for my reserves, guard and reserves, and so on. And our response to that was to set up a clinic for returning combat veterans that really was looking at the various ways that the deployment impacted their health, how it impacted their health physically, how it impacted their health psychologically, emotionally, spiritually, how it affected their families, and we came up with a model of integrated care to support Gulf War veterans. It became the Gulf War Veterans Clinic. That eventually morphed into what we called in the VA deployment health clinics, or turned into what we call the Post-Deployment Integrated Care Initiative. I have never, the first veterans as I came back, I would not have said this is in your head or I think this is a mental condition. I would have said, you're having trouble. I don't know exactly what all is going on, but I know you've been off to war. I know you've been exposed to a lot of things. I know you've had some very difficult experiences, and let's see what we can do to get you back on your feet. I've had an eye on two things. One is the sort of research that Dr. Gollum and Roberta and Lee Steele have been doing to try to figure out what's the cause of this Gulf War illness that's very discrete. Clearly, we have higher rates of these symptoms and this problem in Gulf War veterans than any other cohort I've ever seen. The research is important. At the same time, we had to have a way of helping people. And so our clinical focus has been, how can we help you get back on your feet by providing you with good integrated care that includes symptom management, that includes medications when they're appropriate, that includes...
Are the psychiatric drugs most effective, you believe, or what have you seen in...
I think the most effective thing is good health care, is appropriate evaluations and treatments for diagnosable conditions, getting people resources they need through service connection. This is the first time we've given service connection.
Excuse me, sir, I mean, that's general. I'm asking about psychiatric drugs. Are they effective in the treatment or not?
They're effective in the treatment for indicated conditions. If a person, one of the problems we had, and Anthony, I was thinking about this when you were talking as well, because of the suicide issue, if we see Gulf War veterans that have unexplained symptoms or Gulf War illness, they may also have concurrent or co-occurring depression, and they are at risk for suicide. And so it's very important that we don't look at this as either or. And if a person has a mental health condition, that they get appropriate treatment. Which
my concern is it seems like the psychiatric drug approach seems to be where the simplest choice for the VA to make.
I would not say that.
And I appreciate you disagreeing with that. Last thing, I want to ask a question of Dr. Corey Slechtal. In your recommendations, you do suggest no further studies should be undertaken on cause and effect relationship because you don't have definitive and verifiable individual veteran exposure information. Is that correct? Is that your recommendation?
There were no measures made of internal exposures of veterans, and there were no measures made even of environmental exposure levels. This is basic principles of toxicology and pharmacology.
So in your opinion then, and I understand that, in your opinion then, all the previous studies that attempted to determine that, are they invalid then?
I don't think you can rely on self-report because there will be people who were actually exposed who don't even know it.
This is not about self-reporting. It's whether you have definitive or verifiable individual veteran
I think
exposure.
it's possible to get those kinds of measures, and that's what I stressed before, that in the future, we need biomonitoring devices and GPS tracking devices so we can, in fact, get that kind of information and make those associations.
Okay, and I understand that. I was just trying to figure out whether you thought we had that in the past And to me, that calls in question a number of these studies if we don't have that type of information. Lastly, you do request additional studies of sex-specific and race and ethnicity-specific health conditions. If we don't have the individual exposure information, how do we determine?
Well, there may be, we know a lot of diseases and disorders differ in their manifestations by sex or by race, ethnicity.
But if we don't have the exposure information,
We
which is
don't-
the key
I
variable,
think
how do you
it's a
study
different
that?
point. It's a different point. The exposure information, what this committee has said is that we'll never be able to understand how those exposures actually related to these health outcomes. We don't have any objective
We don't know whether they have exposure or not, is your point.
Sorry?
We don't know whether they have exposure or not, is that the claim?
We know there were exposures. What we don't have is actual information for individuals that we could look at it in relation to health outcomes.
Well, I understand.
We know there were
So-
exposures.
So I don't know how you do your second round of studies that you've recommended. You say abandon the first round, but the second round you're talking about race and sex.
We're just saying for any health outcomes, because oftentimes for many different diseases and disorders, their manifestations and sometimes their mechanisms differ by sex and by race, ethnicity. In order to really understand and or treat them, you may be doing it very differently. Heart attack is very different in a man and a woman, for example.
Yeah.
So we need to break those out and look at them.
Thank you, Mr. Chairman. I just found it concerning that the basic exposure information is, we're hearing that, well, we don't know what it is. And so if you take that variable out, I mean, that strikes out a lot of information, a lot of data, and a lot of research would be thrown out by the Institute of Medicine. And we spend a lot of time, attention, and money trying to figure this out. So very concerning. I yield back.
Thank you, Mr. Schultzkamp. We'll have one more round if anybody else has questions. I do have two questions. Mr. Winnett, could you join us at the table? Mr. Winnett, on your Facebook group related to Gulf War illness, you asked how many veterans are being referred for psychiatric or psychological treatment. What kind of response are you getting?
In a word, overwhelming, sir. Can you hear me okay?
Is that on? Microphone on?
In a word, the answer to that question, Congressman, is overwhelming. I might add that yesterday we hit the milestone of 10,000 veterans. This is a closed group, and I approve every member and have so for the last 7 years. Overwhelming. And my written statement for the record includes quite a number of them, but obviously not all of them. But I took some of those that were very compelling, and I think they're self-explanatory if you read my statement as to what the prevailing attitude is about VA's treatment of Gulf War illness.
Thank you. Now, Mr. Benz, could you please come to the table? Mr. Benz, given VA's use of IOM reports in the manner we've discussed, are you aware of any requirements for such reports?
Yes, I am. The Congress ordered these IOM reports. And in the law, it specified very clearly what it wanted the IOM reports to consider. It listed 33 toxic exposures, including all the ones that have been mentioned here. And it asked whether in the medical literature there was an association between any of those toxic exposures and illness in humans or in animals. Congress did not ask whether there was data on the individual exposure levels the troops received, because it was known at the time the law was passed that that information was not available. But it did want to have the information on animals because most studies of toxic substances are done in animals. When VA contracted for these studies, however, they did not contract for considering animal studies. And the Institute of Medicine was a willing accomplice. in that it removed consideration of animal studies from its standards of evidence, which it had used in the case of Agent Orange evaluations for Vietnam veterans. So the action taken was exactly the opposite of what Congress ordered. And as a result, that entire stack of reports, which you see, no IOM report has ever considered animal studies in its conclusions, and no IOM report has ever found an association between a toxic exposure and the illnesses that we're talking about today. And I want to just clarify, because there's been a lot of discussion today about how complex this is. And certainly going forward, it is complex to find treatments, but well worth the while. But what is not complex is understanding why these veterans are ill. You do not have to measure each veteran and have a monitor on them to know that. Our report, the report of the Research Advisory Committee that was done in 2008, here it is, it reaches very firm conclusions on the fact that these illnesses were caused by toxic exposures, notably the ones Dr. White mentioned, PB and pesticides. There is no dispute about that if you consider animal research, but the IOM has never considered the animal research. They talk about it. They have paragraphs on it. But when you reach the conclusions, they use a standard of evidence which excludes animal studies. Please read my submission, and you will see that in detail, that the entire IOM reports, if you read the reports, they're very clear, they're very honest. They say, we don't consider these animal studies. And we're talking about basic things here. Here's 2 pages with 23 studies of the effect of low-level sarin, such as was experienced at Camisea, that was considered by the Research Advisory Committee and has never been considered by the IOM. Dr. Corey Selecta's report on page 139 says that she didn't consider the animal studies because they were relying on earlier IOM reports. Well, if you read the earlier IOM reports, as I indicated in my written submission, they didn't consider them either. These are the basic studies that say the toxic substances are toxic. So the whole IOM series of Gulf War and health reports is a stack of cards. And the same dishonest standard is being applied to current veterans of Iraq and Afghanistan who have been exposed to burn pits. Once again, there is no consideration of the standard that Congress itself established.
Thank you, Mr. Benz. Ranking Member Custer, you're now recognized for 5 minutes.
Yep, thank you. This is a question for Dr. Clancy, and again, my exposure and my experience doesn't compare to anyone serving in wartime, but part of the complication that I experienced with my lungs was I was told that I had the lungs of a 90-year-old smoker. And I've never smoked a day in my life, and I consider myself a healthy person, but that's the kind of damage that can be done. I'm much better now. But I'm curious, and this goes to Dr. Clancy, maybe Dr. Hunt, on the long-term impacts. This is a quote from the, well, we know from the IOM and just generally that cancers have a long latency period, 20 to 30 years in the case of lung cancer. This is a quote from the Lung Cancer Alliance from the written statement. The median age for cancer diagnosis in the United States is 65, 70 for lung cancer, and the median age of Gulf War veterans, 1991, was 28. So add 25 years, we're coming up on this cohort of veterans being 50 years or older. And I'm wondering, is there any action being undertaken by the VA, or could we encourage you to do that, where we would be providing lung cancer screening to Gulf War veterans that we have on the registry, or at least an initiative VA-wide where we would put the word out for Gulf cancer veterans to get this type of screening? Can you tell me the status and just what that would look like and how we
So
could move
just to be
forward.
clear, we have pretty well-developed cancer registries for most of the major cancers, and I think the Institute of Medicine report was very clear that would probably be the most fruitful place to identify an increased incidence. We could certainly explore lung cancer screening for some of these folks, and I actually think that's a very intriguing idea. About 60,000 people have voluntarily signed up to enroll in the burn pits registry. The only caveat, but again, I think this would be interesting to learn, the lung cancer screening studies were done on smokers. Whether it will
Right.
be as productive in identifying early nodules and so forth in people who have lung damage for another reason is an open question.
Yeah.
I will say it's something the VA has been looking at for a few years. Not just can we get veteran screening, but also can we do the appropriate follow-up, because the price tag on reducing mortality rate for lung cancer, it's the only thing we've got, right, is this new kind of screening. It reduces mortality by 20%. Nothing else we've ever done works like that.
Yeah.
The flip side of it, though, is you have a lot of false positives, so people need to be followed up very, very carefully, and we've been looking into that for several years.
The other important thing for the committee to know is that our approaches to more proactively addressing exposure concerns following deployment are sort of demonstrated very clearly through the Airborne Hazard and Open Burn Pit Registry. Now, when folks come back from Iraq and Afghanistan, they can go online. They can document their symptoms, their concerns, their exposures. It goes into the clinical record. They come in and they have an exam. So we're really starting the moment people come back to look at potential sequelae.
So maybe what we're talking about then would be to take that approach and go back to the Gulf War veterans to bring them into that. And I understand we don't have the specificity. I get the frustration from the science side of wanting to know, but I also feel that people have had exposure, and without even knowing the specificity, at least we would have an understanding. Even a 20% drop in mortality is significant. So, and I just want to associate myself with the remarks of Mr. Walsh that maybe that is the approach that we need, is a center of excellence for toxic exposure, toxic wounds. And I also think that, once again, the VA could be on the cutting edge for the civilian population in terms of understanding our exposure to all kinds of toxic substances. So,
and that's why engaging people in care is so important too, because the best way to pick up malignancies is to have people involved in regular care. So prescribed screening occurs, and so if people have symptoms, we're more likely to pick things up more quickly.
right, and I think that this way you could bring people back in and through their regular care have the conversation about, we would recommend, and I understand, look, CTs for everybody in the world is going to be expensive, but to me it's very important that we show that kind of care and concern. I wasn't in Congress 25 years ago. I regret that people were treated this way, and I think we have a bipartisan support here to do better going forward. And again, thank you for your service, and for all of you for your interest today.
Thank you, Ranking Member Custer. Our thanks to the witnesses. You are now excused. Today, we have had a chance to hear about the problems that exist within the Department of Veterans Affairs with regard to treatment of and current health outcomes for veterans suffering from Gulf War illness. The lack of progress that has been made by the department in the 3 years that have passed since many of these problems were highlighted by this subcommittee is both frustrating and disconcerting. I believe Gulf War veterans deserve better, so I will be exploring options on how to best address these matters in the coming weeks. I ask unanimous consent that all members have 5 legislative days to revise and extend their remarks and include extraneous material. Without objection, so ordered. I would like to once again thank all of our witnesses and audience members for joining in today's conversation. With that, this hearing is adjourned.